I think we'll get started. So good morning, everybody. It's an early morning for us here and perhaps a little bit later on for our colleagues who will be joining in from Hong Kong. This is a joint rounds between University of Hong Kong with Dr. Kendrick Shi, who's on, as well as our center. They've had an amazing rounds, the very first round. So now we're paying back the rounds favor. And today I'm very happy to have Dr. Mona Koaik, who is our cornea intersegment refractive surgery fellow. For those of you who have not met Mona yet, she's an energetic, enthusiastic, and talented cornea person, up and coming. And we've gone through a few of these cases. We thought we've talked about iris cysts. We're dealing with some interesting cases lately, and once in a while these pop up. And so I thought we would talk about this. So Mona did all the heavy lifting and prepared this presentation. And Mona, please let us know what you've learned about iris cysts.
Basically that I didn't know anything about it before. Well, thank you, Dr. Beck, for actually letting me do this presentation. These are cases that you've done, one with me, one with Dr. Morales, our previous fellow, and I'm very happy to be able to share them with you guys. I'm going to be talking about irises. I'm gonna go really basic with them, just so that we actually have an overview about it. Basically, how we're gonna go through, we're gonna present the first case. We're gonna talk about the different types of cysts and the different diagnostic modalities that we need to have. We're gonna discuss our differential diagnosis, and we're gonna discuss possible treatment options. And then as a teaser, we're gonna discuss our second more challenging case and some take-home notes at the end. So first, let's start with our first case. This was a 73-year-old female who presented to us in 2017, December 2017, with the PBK of the right eye. And she had had cataract surgeries for both eyes 4 years prior to presentation. And on exam for the left eye, we found an incidental cyst that was not noted by the patient and was not causing any symptoms. She did not have any trauma history, and she is a recent immigrant from Somalia with no other family history or review of system that is contributing to the history. Medication-wise, she was using Miro for the right eye, and that was about it for her exam. On slit lamp, what we saw was this peripheral iris cyst that was about 3 millimeters in size. What we could tell from this iris cyst is that it was transilluminating, and it was fluid filled, and there was no synechiae and no corneal decompensation and no disruption of iris tissues. The vision in the left eye, which was the eye affected by the iris, was 20/25. The right eye at presentation had the PBK, so the vision was pretty low, and IOP was normal in both eyes. So we went ahead and did the UBM upon presentation for the left eye, and what the UBM showed was this beautiful round cystic lesion of the iris with posterior bowing of the iris tissues and adherent to the angle in just that one structure, but no other angle abnormalities, no synechia, and you could see the PCIOL well placed with no tilt, no disruption. And that at that point with that UBM, would anybody have done anything for this patient? Would anybody have intervened?
So for me, it was just watch it right now because we were kind of focused on the other eye.
On the other, yeah.
Yeah.
That was pretty.
It was small, but this is a nice image, and I think some of our ultrasonographers probably have a bit of experience in terms of detecting and talking about these. And just from Dr. Shi, he said, okay, so he said he's had a previous case like this, and it just spontaneously became kind of flat. So
and it was post-surgical?
Let's see what he says, but
okay.
Yeah, he said, but basically it spontaneously became that way, just kind of not an issue afterwards.
Yeah. So for us, we didn't have really much of an option. We had to deal with the PBK that was causing her a lot of pain, and that was her good eye. So in the process of dealing with her PBK, we were seeing her every couple of months, maybe, until in March 2019, which was just when COVID hit. Her vision dropped to 20/60 in the left eye from 20/25. And on exam, we could see an enlarged cyst that was engulfing most of the anterior chamber, adherent to the corneal endothelium, still transilluminating and displacing the iris, but is not causing any synechiae or any iris abnormalities. And the pressure was normal in the left eye at that point. On UBM that was done back then, we could see a very large iris cyst that was engulfing most of the anterior chamber, and you could see a posterior displacement also of the iris, but without any IOL dislocation or any IOL tilt. So the question here is how to proceed next. What would you do? What are your thoughts on this? If anybody can.
Mona, maybe you can go back to the previous slide with the imaging.
Sure.
And if the attendees, I think you're able to chat, if you're able to kind of click your button there. Kendrick mentioned that the case that he saw was followed by uneventful cataract surgery many years after. Yeah.
Oh, okay. So it was spontaneous cyst.
Yes. These are nice pictures.
Yeah. So in terms of what this cyst is, we need to look back at the literature and kind of see what types of cysts are arise from the iris at this point, and what is our differential. So I went back and looked. There are two different types of cysts that can arise, major categories: the primary iris cyst and the secondary acquired cyst. The primary cysts are those that arise either from the pigment epithelium or from the iris stroma. And in some points, the pigment epithelial cyst can dislodge and can become free-floating in the anterior chamber, as you will see in a bit. The secondary cysts are more related to secondary causes of cysts, including either epithelial downgrowth causing post-traumatic cyst, or kind of low-grade inflammation causing due to drugs, parasites, tumors, uveitis that can cause all sorts of iris cysts. So we really have to keep an open mind as to what the etiology of the cyst is, and that can contribute to why it would change over time. A lot of cysts could be drug induced, and those can regress over time. So maybe that was part of the case with Dr. Shi, because if you're using prostaglandins or some kind of drops, they can actually have a cyst that regress over time. For the primary cyst, the most common parts are the iris pigment epithelial cysts. They involve about 60% of all primary cysts. And usually what we see with them is an obvious convexity of the iris plane. In this picture here, you're seeing a cyst that is peripheral in origin, and thus it will transilluminate a little bit. Whereas if you see the cysts that are arising from the pupillary margin or the mid-zonal pigment epithelial cysts, they're usually darker in color and they do not transilluminate. And in those cases, they can be mistaken for nevi or for other kind of masses. And these pigment epithelial cysts can dislodge and can free float in the anterior chamber. When they do that, they're rarely malignant, and we rarely do need to actually intervene. They might cause some pigment dispersion syndrome, in which case we would want to treat. Otherwise, pigment epithelial cysts are very stationary. They can occur at any age, and they don't usually require a lot of intervention, especially because they don't cause a lot of deformity in their surrounding structures. The other type of primary cyst arises, instead of arising from the pigment epithelium, it's arising from the stroma, and these can be either congenital or acquired. Congenital forms can appear in children, and they are usually much more progressive in nature. They're much more disruptive for the iris tissues and for the ocular structures. And typically, most studies say that we do need to intervene for stromal cysts because they do cause a lot more damage surrounding them. They are transilluminating, and they are larger than a regular iris pigment epithelial cyst. If they are acquired, So if they occur later in life in adults, they don't tend to be as progressive as they are when you're with children. So it is a pretty aggressive situation when you face it in children. For primary cysts, as we were saying, 85% are most commonly 85% are pigment epithelial cysts, and that's based on a study by Shields et al. In 2012 that involves 768 cases of iris cysts. And you can see from the distribution, the epidemiological distribution, that you can find a lot of mid-zonal and peripheral cysts in adults and senior adults. And knowing how the mid-zonal cyst looks like dark shaped with bowing of the iris and everything, we really need to think about other pathologies that can come with it. And everybody is fooled by these iris cysts. Almost 200 of the patients who were referred to the Shields in Philadelphia in 2012 for iris melanoma referral, 76% of them were pseudomelanomas, and 40% of these cases were actually primary iris cysts and mid-zonal cysts that were mistaken to be melanomas. So it's really important for us to think about those malignancies and malignancy-related cysts that can arise in the elderly population, especially like in our patient. And usually they're on the differential not of peripheral cysts, but mostly mid-zonal and papillary cysts. And you can think about melanomas, you can think about medulloepitheliomas in kids, and leiomyomas and adenomas of the pigment epithelium. And the way to differentiate them clinically is actually very nice. First, you can look at how the cyst is looking. If it's smooth, if it's homogeneously dark, then it's most likely a primary cyst. A heterogeneous mass, irregular contouring, we're talking more iris tumor. As you can see from these pictures here, the one on your left side is a picture of an iris tumor, mid-zonal, with bowing of the iris, a fusiform lesion before dilation. And when you dilate the iris, you can see how it elongates and it becomes very smooth. That is characteristic of mid-zonal cysts. If you're seeing those changes, they are not an iris tumor. You don't need to worry about them. Also, look for any sentinel vessels. A lot of times, sentinel vessels can be a telltale for iris tumors, as we know. In kids, do keep in mind sentinel vessels, but also do keep in mind a wide-shaped appearance. That could be a medulloepithelioma that we don't want to miss because of the hyaline cartilage deposit within the cyst. It gives you that whitish color with all of those sentinel vessels, and that can be very damaging to the eye, so we need to detect it early. So now that we've discussed primary cysts, and now that we've discussed primary cysts in the elderly population and how to differentiate them from cancers, let's go to a little bit more of the secondary cysts, which are not as benign as your regular primary pigment epithelial cysts, mainly because they do cause a lot of signs and symptoms and a lot of damages to the eye. They do cause decrease in vision. They can be progressive with a lot of uveitis, glaucoma, cataract. Sometimes you might see extropian uvea, neovascular glaucoma, and again, they do cause a lot of distortion of the anterior segment architecture. Again, pigment epithelial cysts do not cause any anterior segment distortion, which is really good. Stromal iris cysts, primary stromal iris cysts, do cause a little bit of that, especially in children, less commonly in adults. So. The first type of secondary cyst, and which is the most common type that we see a lot, is the post-traumatic implantation iris cyst. And these occur because of either trauma to the iris, prolonged hypotony, wound dehiscence, leak after a trauma, or after any kind of ocular surgery, specifically big wound ocular surgeries. And usually what happens with those is that the epithelium can find its way into the eye and form either a serous kind of cyst, which is kind of what we're seeing in this picture, versus a pearly cyst, which is opaque and raised, or it can form an epithelial downgrowth. So the main mechanism of post-traumatic cyst formation is basically an introduction of epithelial cells into the anterior chamber, and then a spread of the endothelial cells across the iris, the cornea, or a spread into a cystic growth. the literature doesn't really know what mechanisms shifts the epithelial downgrowth into going just into a downgrowth with a sheet-like layer versus a cystic growth, but it's basically the same mechanism that's happening here and there. So with serous cysts, which are the most common type of post-traumatic iris cysts, they usually go into a phase of implantation. They pinch off and then they slide over the ocular surfaces. They find their high vascular area, so they love our iris, and they can extend and proliferate and go into the angle, go into the cornea, and attach to the endothelium. If they don't form a cyst, they go into an epithelial downgrowth, and we see it usually with a gray advancing edge over the endothelium. Pearly cysts are very rare, but they do happen if you have any foreign body inside the cyst, or if you have any cholesterol deposits or mucus deposits. I saw a couple of articles that discuss how to manage them. I won't go into them because they're fairly rare to see. Otherwise, you might find drug-induced cysts, parasitic cysts from cysticercosis, post-uveitic cysts. All of these cysts can happen and regress depending on the inciting event that surrounds them. So how do we differentiate these different types of cysts? First, your clinical exam is important, but we really need to depend on our COMT friends here today who help us do a very good UBM to kind of be able to differentiate where that cyst is coming from and what is the structure of the cyst. It's important to, I'm going to highlight a few things in this table that I want you to take home. First, that the thickness of the wall can be a relative indication of post-traumatic cysts. They're usually bigger because they're epithelial cells. Usually, most of them are fluid-filled. If they are not, we're thinking about either pearl cysts, which are not that common, or malignancy. But it's very important to also look at the location of the cyst in terms of the iris. So is it causing iris disruption? If it is causing deformity, it's either a stromal cyst or a post-traumatic cyst, because these usually arise from the iris stroma, whereas the one that arises from the pigment epithelium does cause bowing of the iris, but does not cause gross deformity, and that is the main difference. Also pay attention to sizes in order to differentiate the pigment epithelial cyst from the stromal cyst. Pigment epithelial cysts are usually smaller in size, less than 3 millimeter. If you see any neovascularizations, then you're thinking about malignancy. So just to show you some pictures of very turbid cell wall content with a medium kind of wall reflectivity versus an iris cyst with a low cell wall reflectivity and a clear content. Post-traumatic, iris pigment epithelial versus a pearl post-traumatic kind of cyst. So back to our case. What do we think about this patient? Just as a reminder, we had a big cyst that is engulfing the anterior chamber and causing some posterior bowing of the iris with no IOL dislocation, no corneal decompensation, no glaucoma. This patient did have cataract surgery, but she had a phacoemulsification. She did not have any trauma history. She did not have any ocular structure damage. We did see on exam that the iris is displaced a little bit. She is an older female with progression over a 2 years period. So my first thought was maybe this is due to phacoemulsification. Maybe this is a post-surgical kind of iris cyst, and this is a secondary type of iris cyst, and especially due to the progression. So I went back to the literature, and in fact, we rarely, if ever, do see any iris cyst post-phacoemulsification. We do have an incidence of 0.12% of iris cysts after extracap and intracap, which were the larger wound cataract surgeries. But with the phaco cataract surgery, with a smaller wound, we do have much less risk of epithelial downgrowth unless you had a wound burn or constant wound leak that might exacerbate this. So we're really not erring on the side of having it as a secondary post-traumatic cyst, but it is most likely an iris pigment epithelial cyst that, unlike what the literature has showed us, it did progress in this patient in an elderly patient. It did not look malignant at all on exam though. So in order to treat it, because it has been causing a loss of vision for this patient, we went ahead with a surgery that involved alcohol sclerosis of the cyst wall and eventually cyst excision. We start initially with doing a small stab wound and filling the chamber with viscoelastic to kind of tamponade the cyst leak, and then aspirating using a 30 gauge needle the content of the cyst, and you can see how beautifully the cyst wall is going to shrink bit by bit here. And then we're changing our syringe. It's very important to keep everything stable because you don't want to puncture that iris cyst wall when it's that small. We're changing the syringe to kind of put 100% alcohol ETOH and inject it back into the cyst. Our main change on this technique is that we added vision blue to the ETOH, and the main reason for the vision blue is that we wanted to be able to detect any leak of the ETOH into the anterior chamber. The main reason for that is that we're trying to avoid any anterior chamber inflammation and any synechial formation on the long term. As you can see, we do the first cycle, we put the alcohol, wait about a minute until the alcohol is taken in, and then wash it out again and re-inject the alcohol again. You will see here, I'm not sure if you can notice it very well, but we did have a small ETOH leak, and that was, we were able to detect it using the vision blue. So we washed it out with VSS, refilled with viscoelastic, and continued with our second and third cycle of alcohol treatment. And you will see that after the wall has become a little bit grayish white. We can't really tell from the trypan blue, but usually we're expecting it to be a little bit gray white by the time we try to excise it. We release it a little bit from the endothelium and using a reverse Sinskey. And we took it out using MSTs, but even because of how adherent it is to the other structure, we did have some iris damage and iris tissue damage because of how adherent that cyst is to the iris structure. So postoperatively, you could see here that you still have some retained cyst wall over the endothelium, and you can tell from this picture that you still have irregularities over the endothelium, and you do have a very tiny retained cyst after the procedure. The pathology of the cyst is as we predicted. It's a primary iris pigment epithelial cyst, which did not behave, which was not very stationary and was actually progressive. The take-home message from this is, right now we did her surgery actually for DMEC to kind of treat this and improve the vision because this was her better seeing eye, and the vision is still today, 2 months after the DMEC, at 20/50. The take-home message from this patient is that pigment epithelial cysts do progress, so we really need to keep an eye on them. And the other thing is they do affect the vision even though they are benign in nature. So what are our treatment options? There are multiple options available to us. First and foremost, we can always decide to observe cysts and not treat them, especially if they're primary cysts, especially if they're stationary. Always do UBMs at slit lamps at regular follow-ups to detect any small changes. Primary cysts do have a high rate of recurrence, especially when they occur in children. And reasons to intervene would include stromal cysts in children, secondary cysts, or any cyst that's affecting the vision or causing disruption to the ocular structures. And from this point, we move to other treatment options that are available. Fine needle aspiration can be a simple option to kind of deal with a lot of the iris tumors. It could be a diagnostic tool because basically you just take a 30 gauge needle and you go transcorneal and you sample the fluid and you kind of deflate that iris cyst, and that can help you diagnose, can help you tell what the next steps will be. If you only do fine needle aspiration, you're expecting the cyst to recur after 1 to 3 years. Common complications of fine needle aspiration is leakage of the seepage of the fluid into the eye and causing a lot of inflammation, IOP elevation, hemorrhages, glaucoma. So in addition to fine needle aspiration, like we did in our case, we might want to actually inject some alcohol into the anterior chamber. This is the technique by Shield et al. Published in 2014 that uses this 3-way port in which they connect a 30-gauge needle to a 3 ml syringe and a 1 ml alcohol injection. It's a 100% alcohol. The reason why this is a nice advantageous device is that you don't have to keep going back and forth so that you don't rupture your cyst while you're changing your needles. But you do have to make sure not to have an air bubble in your system, because that can inadvertently rupture your cyst and lead to more seeding of the epithelial cells into the anterior chamber and seepage of the fluid, which can lead to a lot of inflammation. Another good tip is to actually use some viscoelastic around, like they're doing in this picture, around the iris cyst, so that they can tamponade it from seeping out while they're aspirating it and treating it with alcohol. The end outcome of the alcohol sclerosis is to see on your exam during the surgery a whitish, grayish discoloration of the iris cyst. That would tell you that the cyst wall has been deepithelialized. And typically you use 100% ETOH, and it's been called for to be used for 1 to 2 minutes, 3 cycles per treatment. You could also inject mitomycin C or 5-FU inside the eye. 5-FU has been used also for epithelial downgrowth and intracameral injections. These are more case reports, kind of incidental reporting, but you could always think of them in your resistant cases. In this study by Shield et al., she looked at 16 eyes of iris stromal cysts that have had previous fine needle aspiration but still recurred after the fine needle aspiration. And they report 14 out of the 16 eyes to have completely regressed and involuted after using alcohol sclerosis on them, with 12 of them only needing 1 cycle, 1 treatment of alcohol sclerosis, whereas the other 4 needed multiple cycles that were done few months apart until you can totally regress your cyst. And they showed very beautiful pictures. The first set of pictures here are after 1 cycle of alcohol sclerosis, and this was after 3 different cycles of alcohol sclerosis. And you can see how the cyst completely regressed. Vision in the first patient was not as good after this, because the cyst did cause a lot of cataract that needed subsequent cataract surgery to be dealt with. Complications of the alcohol, as we mentioned before, cataract, synechia, anterior segment inflammation, especially if the alcohol seeps out, and the cyst can adhere, like in our case, to the endothelium and cause endothelial compromise, which can require further surgery. Always pay attention to glaucoma in these patients, because any seepage of the cyst fluid can cause inflammation and glaucoma. Moving on, you can also opt to choose laser. And you can either use argon laser, which destroys the epithelial cells, or YAG laser, which actually anecdotally you can do a cystostomy with a YAG laser, cause the fluid to leak into the anterior chamber. The only note to keep, if you want to do that, there's only been case reports about it, is to keep the patient on a lot of steroids, because this causes a lot of inflammation, and to give them a lot of glaucoma medications to prevent any IOP spikes. I like this case from Shin et al. Published in 2000, because it shows how you can use the fine needle aspiration to kind of release the cyst wall using a 30-gauge needle, and then using an endo laser with an argon laser, just laser the base of the cyst until you have a whitish grayish discoloration here, and that should resolve the stromal cyst completely, as mentioned by this case. So you can do 2 different techniques in one go. or you can go for surgery and excision. Usually when you're considering surgery and excisional surgery for the iris cyst, you have to consider anterior segment procedure that include either resection of the iris, removal of the lens. If you have an IOL, you might want to IOL exchange it, or you might want to do a PKP or treat the glaucoma, or endothelial keratoplasty too. In this study by Rishi et al. In 2008, out of 10 cases who had post-traumatic iris cysts, almost 40% of them had poorer visual prognosis after the procedure, and that was related either to glaucoma or to corneal dysfunction due to the iris cyst. And they noted that the vision dropped from an average of 0.5 logmar to an average of 1.6 logmar after the procedure, despite their best efforts. So really excisional biopsy, excisional treatment for these lesions should be reserved as a last option because it does disrupt a lot the eye, the normal anatomy of the eye, and it can cause further complications. These are not benign cysts, and a lot of time, like we saw in our case, we do have some remaining damage inside the eye. So Rao et al. Actually advised on using a stepwise, minimally invasive approach to treating iris cysts. Always prefer observation whenever observation is available. Fine needle aspiration is a very nice second option if you want to be diagnostic. And just keep in mind that these will recur within a few years if you don't need any further treatment. Alcohol sclerosis is a nice technique that can be done multiple times, and you can combine it with lasers that treat the retained cyst wall so that they don't come back. I don't really like the idea of a YAG laser with a cystostomy, but that can be an option for you. And in the end, en bloc excision with try to minimize the amount of anterior segment surgery to be done to kind of minimize the damage on the long term. That being said, I am going just to tease your brain with one last case. This was a fairly recent patient of ours. He's a 13-year-old boy. We started treating him back in 2017. He was referred to us after he had a penetrating trauma at 5 years of age. He was back there 13 years of age, and he had an incidental mass on the iris found by his optometrist. The globe rupture was done in 2010, and he was still on prednisolone once daily for the right eye. His vision was 20/30 in the right eye after the globe rupture. You can see a correctopic pupil. You can tell a very tiny start of a small cyst with a limbal kind of lesion overlying it. And he had some synechiae to the anterior chamber and some iridocorneal adhesions. On UVM at that stage, we did see a small cyst with no cataract, no other abnormalities. We kept following up this patient every 6 months with continuous UVMs. He comes back, actually, I'm sorry, this was in March 2020, just before COVID started, and he comes back with an acute onset drop of vision in the right eye. Vision went down to counting fingers, pressure went up to 36, and you can see a multiloculated iris cyst that is transilluminating, is fluid filled, and it is disrupting a lot of the iris structure surrounding it. As you can notice, he has a lot of synechiae, he had iridocorneal touch, and he was starting to form band keratopathy and corneal decompensation. And underlying it, you can see it on this picture, he was starting to have some cataract. So we did a UVM. Of course, the UVM, because of COVID, took 3 months. Again, this is in June 2020, not in June 2019. On UVM, we could see an ecclucent fluid-filled cyst, with medium wall reflectivity. You can see that the iris stromal tissues is split, so this was a stromal kind of iris cyst. And on the B-scan, you can tell a posterior extension of the iris cyst. Seeing this, what would you do for this patient? How would you proceed to actually treat him? Any ideas? And the other question about this patient is how aggressive would you be and when would you be aggressive? Would you actually start treating him when he was younger, when he had that small 2 millimeter cyst at 13 years of age, or would you wait on him until he develops that big of a cyst?
So we have one comment said, probably consider consulting our vitreoretinal colleagues.
Yes, we did consult our vitreoretinal colleague, and we were at a loss once the cyst was that big. We opted to go with a minimal approach, a minimal staged approach. So we actually did the surgery yesterday. All we did was a fine needle aspiration of the iris cyst. We just went in with a 30 gauge needle and we aspirated the content of the cyst. You can notice when we do that how the whole cyst is going to collapse. We managed to take out about 0.6 ml of fluid from inside the cyst that was disrupting all of the structure. You can see it going down right now. We're still waiting to see on follow-up UBMs what will happen to that cyst and how is it looking in the posterior fold. The main benefit of the fine needle aspiration, in our opinion, was diagnostic, so that we would be able to tell what structures are supposed to be treated next. Based on the studies that we saw for post-traumatic cysts, it's not really uncommon to see that much damage to the ocular structures because of the cyst, and we have to go step by step in the management treatment. So take-home messages. Most of the cysts are benign in nature; they're not malignant. But you still need to perform UBMs and B scans because they can invade and disrupt ocular structures. Always tackle post-traumatic cysts and primary stromal cysts because they tend to be progressive, especially in kids, for the stromal cysts. If you have an advanced cyst, go for a staged approach. Do the minimally invasive procedures first before you proceed to other ones, especially because you have to keep in mind the high rate of recurrence and the high complication rate associated with these cases. Most of them will have delayed visual rehabilitations, if any. These are my references, and thank you. Any questions? Thanks,
Mona. Yeah, maybe while we wait for some comments in the chat or some questions that come up, that last case was interesting because we were, as you recall, we were quite uncertain of which way we should proceed. Our previous experience of doing the aspiration and sclerosis with alcohol, but at the same time doing the excision, perhaps at this point we're thinking, should we do an excision? As you mentioned, the literature shows that we should kind of do a very kind of a slow approach, and maybe an excision may not be the best thing. We definitely consulted our retina colleagues because if we were doing this aspiration or even this sclerosis, we're thinking what would happen if this were to rupture, especially posteriorly, and having 100% alcohol going there, because the UVM did show quite clearly this was a continuous cyst that was going from the anterior to the posterior part of the eye, and so we were worried about that. And then you did some searching in the literature, and we didn't see many cases like this, did we, Mona? Sorry? We didn't see many cases of having posterior extension. No, we didn't see a lot of cases with posterior extension. That's pretty rare. No. And especially with his kind of very fast growth. Right. Yeah. And so, what do you think the role of OCT would be as opposed to UVM? OCT is, a lot of the studies mentioned the UVM because the UVM could penetrate more, especially through thicker wall cysts or through denser structures. And it does have a 4 millimeter penetration, but OCT is kind of a nice way to delineate the corneal structures, to delineate the angle structures, to see how we can intervene differently. Okay. While we're maybe entertaining other questions or comments, I'm going to send out this link which is for us to fill out an evaluation. That's always useful. It helps with the accreditation. And if you guys have a moment, please fill that out. So Mona, what do you think would be the future course of our last patient, our young gentleman who obviously is still growing and has not reached ocular maturity yet? What do you think the next steps are going to be?
I think it will really depend on what we see today on exam at what our follow-up UBM will be. So if we don't have any posterior extension of the cyst, we might want to actually ask our retina colleagues to kind of go in and do a photocoagulation with the endoprobe to kind of seal that cyst wall from the posterior cavity and decrease the risk of recurrence, and maybe after that do kind of an alcohol sclerosis and try to shrink that cyst as much as possible before we try and tackle the cornea and the cataract and the anterior segment synechiae, just because we do need to control that cyst and prevent its recurrence before we actually go ahead with further surgery that would disseminate the epithelial cells into the eye.
Okay. And if we go back to those post-traumatic pearl type lesions, cysts, is the management similar, that you're trying to minimize leakage of these inflammatory intracyst contents?
Yes, we're always, whenever we have epithelial cyst walls, so epithelial downgrowth, you do want to minimize how much leakage happens, and you want to minimize how much the epithelial cells will spread, because both of these will kind of affect the recurrence rate and will affect how much inflammation and synechiae will occur inside the eye after it.
Okay. And so the same thinking applies for these pearl cysts, that you don't want to necessarily excise, but you want to drain.
Yeah.
Okay. All right. Any other questions from the attendees? All right. Well, thank you so much, Mona. I know you worked hard on this presentation, and it shows. The presentation will be uploaded to our YouTube channel for those to look at afterward, for those who would like to look at it afterwards. Thank you again, Mona. It was very informative.
Thank you.
And
Thank you, everybody, for listening.
all right. Take care, and bye-bye, everybody.
All right.